I'm Dr. Ahmed Sabry. I am a cardiology intervention consultant at MANA Groups. Today's agenda, we will start with utility of the IVUS and the assessment of chronic calcification and guiding of PCI outcomes, and we have also one case for Rota cut technique. Actually, we have that IVUS and OCT intracoronary imaging that give us more data about the calcium, this data, and we could see the angiography, there is lack of data, so we need to intracoronary imaging for more deep calcium, calcium arc, calcium thickness, and the longitudinal calcium length. So we have calcium distribution and morphology. We have for the deep, superficial, concentric, and eccentric nodular. This is calcium distribution and morphology. Also, we have the distribution by the calcium quantified by the measure of arc, calcified by location with the plaque. Superficial calcium closer to lumen than the adventitia. Deep calcium is closer to the adventitia more than the lumen. For the superficial calcium, there are minimal non-fibrotic layer, angle of calcium usually measurable, and the deal with by arthrectomy, scoring, cutting balloons, or IVL. For the deep calcium, the presence of the thick fibrous layer, non-luminal calcium, and non-compliant, we are using non-compliant scoring or cutting balloon. For the nodular calcium, this is the most important, characterized by superficial large calcium and negative remodeling, lack of the fibrous cap disruption. Here we need to use arthrectomy, scoring, cutting, or IVL. So we have calcified lesion, so we have deep, we will do with balloon dilatation, or we have superficial or nodular, we deal with arthrectomy, either rotational or orbital or IVL. Then we'll also need to know the IVUS calcium score. According to the angiogram, there is calcium, yes, so we'll do next step is IVUS. We have the maximum superficial calcium more than 270 degrees and more than 5 millimeter length, so it will be get score 1. If the calcium is more than or at concentric with 360, it will be score also 1. Calcified nodule, it gives 1. And vessel diameter less than 3.5, it gives us also 1. So if the score is more than 2, here we need to consider arthrectomy. Why? This because predicting stent expansion. If the score, calcium score more than 2, so the high risk of the stent under expansion, lesion preparation strategy need to be facilitate the plaque modification and the calcium fracture before the stenting. Use either rotational atherectomy or orbital atherectomy or IVL. Also in practical issues of IVUS assessment of rotational atherectomy, the position of the guide wire and calcification and calcified plaque to understand the guide wire bias, avoid massive coronary perforation and dissection and other complications regarding to the distribution of calcium plaque. Also after atherectomy, evaluate the ablation effect and the presence of normal vessel injury. So we have 5 factors significant for influence the result of rotational atherectomy: distribution and eccentricity of the calcium, either deep or superficial or concentric, deep, the degree of guide wire bias, choice of Rota wire, either floppy or extra support, luminal area and diameter, pair size, rotational speed, and motion. For the guide wire bias, we have the calcium here, as we show in the slide, superficial calcium, and we have eccentric circumferential calcium, guide wire bias is variable, and guide wire is very close to the calcification, and at 1 o'clock. So here atherectomy and wire efficiency is to ablate the calcification successfully performed using large size wire. Here also favorable guide wire bias as we look, and also it gives us a good result with minimal injury. Here unfavorable because the wire bias is halfway between the nodular calcification and normal vessel wall. So here may able the ablate the calcification, but also it may be ablate also the vessel wall, leading to the vessel perforation. So in this situation, we have other modification or other tips and tricks, like we can use small pair, 1.25 or 1.5, and also we saw selection high rotational speed is mandatory to minimize the effect of differential cutting. Here we could see the dangerous wire bias because it's almost away from the calcium, and it's more near to the normal vessel wall. And it would be ablate the calcification efficiency using the small part, but it's complication situation. We have 3 possible solutions in this situation. Take advantage of the guide wire bias by use Rota extra support, or use large pair despite of higher chance of the vessel injury, or consider other option of calcium like lithotripsy, IVL, or orbital atherectomy. For the key determined successful of the heavy calcified lesion treated by rotational atherectomy, we have these pictures of the effective rotational atherectomy, like calcium fracture, revibration, and post-stent tenule vessel prevascular tissue. Here some also the ablation effect of revibration, and some complication we could see the continuity of dysadventitia and hematoma. Also the theme, we have this coronary rupture by stack of rotablator or rotabar, or massive artery dissection. The assessment here of the BCI calcified lesion by morphology, guide wire bias, and the assessment of after ablation and BUBA and the stent oblonization. Here we have this, our case is 70 years male with end stage renal disease on dialysis, has a long history of prior BCI from 2018 until he came to our center by 2023, was referred to our hospital again. We have this image, coronary angio, shows severe calcification and also ostial LED. The RCA. We start wiring by cyan blue, and then we did IVUS. Show severe calcification. So here we have the challenging problems, history of repeated ISR based on arteritis, severe calcification of coronary artery association with CKD, ostial LED lesion with high plaque burden, and possible calcium nodule, and thick of the calcification in the main concern. So what is the strategy? So according to the score, it's of course more than 2. So the high risk of stent under expansion and lesion preparation strategy.
2 more minutes, please.
We have lesion preparation strategy need to facilitate the plaque modification and calcium fracture before stenting, either rotational atherectomy or orbital atherectomy, intravascular or IVL. So we started to use Rota bar 2 millimeter with Rota floppy wire and one speed range from 190 to 160 RPM. So this is a coronary angio after the Rota bar. This is the IVUS. So we get, before the IVUS, we get 2 millimeter minimal luminal area. Now we get 4 millimeter minimal luminal area. Then the second stage, we do Rota 2.25. This is now. This now we could achieve 4.78. Here, this is a calcium fracture by Rota ablator and volume reduction and calcium modification. Here we do the cutting, coming to next stage with cutting balloon. And actually, we did double kissing by cutting balloon at this stage. We could reach at 12 ATM by double kissing cutting balloon. And here we, after IVUS, again, we repeated IVUS, and we did get minimal luminal area 6.6. So DS, 5 seconds.
Give us 1 more minute, please.
10 seconds.
Yeah. Hazard.
Yes, wire crossing.
Hazard has
this is final.
There. Yeah.
Yeah. And this is final IVUS. We reach 10.8 at the end. So good stent expansion, apposition by IVUS, and there is no need for final pod. So summary, scientific volume reduction followed by the cutting balloon dilatation after the excellent expansion, bring excellent expansion for the calcified lesion. Double kissing by the cutting balloon is feasible technique for calcified bifurcation lesion. We must always make the best reduction and the modification strategy. In each case, Rota cut technique is considered one of the most effective methods for modification severe calcium plaque. Thank you.
Okay. Thank you, Dr. Ahmed. Just a quick